Doctor of Pharmacy degree in 2003 and a Master's of Science in Pharmacy Practice in 2005 from Purdue University. After several years of community practice, he earned a Ph.D. in Social and Administrative Pharmacy from Purdue University in 2011. He has 9 years of community pharmacy experience, published over 20 peer-reviewed manuscripts, authored 3 book chapters, has given multiple invited research presentations, and has authored over 30 research posters and abstracts. He successfully obtained $2.3 million in federal and state funds to conduct prescription drug abuse research with ETSU colleagues. He was awarded the College Research Award for the 2012, 2013, and 2014-2015 academic years. He's received Outstanding Teacher of the Year Award while at ETSU, has coordinated multiple courses in pharmacy curriculum, has served on ETSU multiple university and college committees, and has served in the pharmacy profession at the national, state, regional, and local levels. And we're happy to have him here today to speak about communication between pharmacists and physicians. Thank you.
Thanks, Dr. White. You all hear me okay? Great. Thank you for having me. It's a pleasure to be here. I have a couple of students of mine in the audience, so I can't lie. I can't tell you anything that I haven't already told them. But I was instructed to talk about pharmacist-physician communication, and I'm primarily focused on community pharmacist to prescriber communication. So I'm going to narrow the pharmacist part a little bit, and then I'm going to expand from physician to prescriber communication. And I titled this Quotes, Quandaries, and Quality. And one thing, I really like quotes, and I like good old quotes, and I want to have a few by the time I die. That's kind of a goal. So far, I don't have any. My kids would tell you I have 2 quotes. One, I'll start out saying honor, and they'll say, your father and mother. And it's about with that much enthusiasm. And then the other one is think, and then they'll say, before you act. So those are my only quotes, and I can't claim either of them. So I've got room to improve in that area. But I'm going to put some quotes in there. I'm not going to expand on the quotes. I'm just going to give them to you. They're all about communication, and then you can see how they apply to your practice and how they apply to you. Communication that you might have with your colleagues, with your patients, and with pharmacists as well. Another disclaimer, I'm going to jump around a little bit, and I hope that I can weave this all together. I'm going to talk some about community pharmacists. I'm going to talk some about prescription drug abuse. That's where I kind of hang my hat from a research perspective. And then I'm going to talk about communication. And really what my research does is kind of combine all of those, and hopefully that'll all come together as a nice product at the end. I don't have anything to disclose as far as financial interests. These are the objectives I'd like at the end to be able to describe the barriers and facilitators to effective physician-pharmacist communication. I'd also like you to apply some patient-centered communication skills to physician-pharmacist communication. They're not as different as they may seem. And how many people have been involved in that being facilitating, taken the communication skills for health professions course? I remember you. How many others? Okay, so probably at least half have done that, so this will be very applicable. So before I do that, I want to tell you a little bit about how I got to here, because I think you need to know who's talking to you. So I started out practicing, and this is not the pharmacy. I could not find a picture of the pharmacy. Actually, this one is the pharmacy. This is Cowan Drugs in Lebanon, Indiana. Lebanon's a population of about 15,000, and there are 2 independent community pharmacies in that town, and I worked at both. And that was where I first got robbed, which was an interesting experience. So I started that in 2003 when I was getting my master's. I worked there 15 hours a week while I was doing master's training. I then stopped after master's training and entered community pharmacy practice full-time. So this place didn't necessarily have a full-time gig, so I had 30 hours a week here, and I had 11 over here in Thorntown, which is a population of about 1,500. And right on the other side of this Coke sign, you can see the back of the building right there is Randall Pharmacy. And that's where I worked. And that store since sold out to Kroger, and Thorntown no longer has a pharmacy in it. So folks have to travel about 20 miles to get to a community pharmacy. In 2008, I switched to CVS. And I did this to get back to the town where we were living. I went to Frankfort, Indiana. It was a population of about 15,000, 16,000, very similar to where I practice in Lebanon, and they're about 20 miles apart. Okay, so this is all in north central Indiana where I've practiced. Okay, then I left CVS. I worked in CVS all through grad school, worked every Saturday. It was a very good motivator to get done with my stuff during the week as far as my Ph.D. was concerned, and took ETSU, Gatton College Pharmacy, as my first academic position after Ph.D. training. So that gives you a little bit of my history. This is my family, and this is where I practice my communication skills. So this guy's 10, she's 7, he's 5, and we just adopted her. This is Katie Ann. So she's almost 2 and is functioning about like a 10-month-old. So very behind developmentally. But this is where I get to hone some communication skills, and I get to see firsthand how you can engage people in behavior change and education. Because talking to this dude isn't a whole lot different than trying to get patients to do what I want them to do at times, is what I've found. That gives you a little bit about me. Anything else you want to know? All right. So what did I notice in practice? I noticed a few things in practice that were frustrating to me and kind of drove my desire to get back into Ph.D. training. I commonly let patient factors determine my engagement with them. If somebody looked like they were in a good mood, I would maybe be more inclined to communicate with them. If they looked a little bit questionable, however you might define that, I refrained from chatting with them. One thing that bothered me too was I hadn't a clue how to have a tough conversation with a patient. I wasn't taught that in pharmacy school. Some of the communication skills that y'all have had, I didn't have. And it's been a real blessing for me to be able to participate in that course and learn right alongside of those of you that have participated in it. The other thing that was a kind of a game changer for me, and it wasn't even that hard of a conversation, but I had one patient who's since deceased. His name was Don. And Don was a friend of mine from church and some other organizations in the community of about 15,000 people. And Don was on max dose lovastatin for high cholesterol. And Don didn't take his cholesterol medicine worth a hoot. And I did not ever have a conversation. He came in for a 30-day supply of lovastatin about every 90 days. And so you can kind of assume, how is he taking that? Probably not correctly, because he came in routinely. So I don't think it was a mail order issue of anything like that. And then Don died of a massive heart attack. And that really kind of got my attention as far as, man, that was not that hard of a conversation to have with him, just trying to inquire a little bit about, hey, Don, I see that you're getting this filled every 90 days instead of 30. Tell me a little bit about how you're taking it. I didn't have that conversation, and that kind of drove me back as well. So we communicated with the NIH regarding a potential prescription drug abuse research project that kind of dovetailed with this. And our premise was that you can have the controlled substance monitor database, you can have all these other things in place. However, undergirding all of it is communication. And we're not necessarily looking at that from a research perspective. And we were on the phone with them, and I had no idea what they were going to say. Maybe that might say that's the most asinine thing I've ever heard in my life. But they said, that's really innovative. And I thought, that's really sad that that's innovative, but that's how it was perceived. And so communication in this area, research regarding communication is really lacking. It's just not there. And I'll tell you a little bit about what is there here in just a few minutes. All right, so let's see what you know. Did everybody have a clicker? Anybody need a clicker? Need 2 clickers. Okay, thank you. All right, is it going to open? Won't open. Won't do it. It's not doing like it did. Let me see here. There's a little exception over here that's popping up for some reason. I'm not sure what that is. Well, that one, we'll just skip the, yeah. Can I go back to this one? Hold on just a minute. Okay, there we go. I think we're going now. How many community pharmacies are located within Johnson City city limits? Sorry for the technology difficulties. Good looking bell curve. Well, 36% of you are right. They're about 24. It depends on where you, I define Johnson City address, and there's a lot of them right outside too. So in Johnson City, there are about 24 community pharmacies. So for those of you that may not be from around here, I don't know if you realize that that's unique. That's a lot of pharmacies, and a lot of those are independents. When you look at the towns that I've come from in Indiana, Purdue University's West Lafayette's pretty good sized town. There are about 5 or 6, and there's only one independent pharmacy in a town about that size, 60,000. Okay, Frankfort, Indiana, the town of 15,000 had 2, CVS and Walmart. So an attraction for me here was the number of pharmacies. It's unique. There's a unique large amount of pharmacies, and especially independent pharmacies in this area. All right. Now, see if I can get it open again. Oh, rats. Here. All right, there you go. How many community pharmacists reside in Washington County? About 100, that's right. There's about 100. That doesn't mean they work here. They may work in a county outside, or there may be people that reside in other counties outside Washington County that drive in or commute into Washington County. But that's about how many community pharmacists are in this county. Hey, it worked like it was supposed to that time. It's the average weekly prescription volume in a Northeast Tennessee community pharmacy. So how many prescriptions do they fill in a week? C is right, around 1,500 prescriptions. So I don't know if you think that's, excuse me, a lot or about right, or if there is an about right number. I don't know how you determine that. If you break that down, just doing a little bit of math with that, assuming a store is open 60 hours a week, so some 10-hour days, 6 days a week. That might be a little high for some. That's obviously for your 24-hour stores, it's going to go way up. So you've got about 25 scripts per hour that you're open. So you've got about 2 minutes per prescription that you're filling. Okay? Pharmacists are required to counsel patients on all new prescriptions dispensed. Oh. True is the right answer. Okay? So the rules of the Board of Pharmacy say that if it's a new prescription, it doesn't matter if you've been on it for 15 years, when you have the new prescription presented to the pharmacy, you're required to counsel face-to-face. Then there's a little out that says if you can't do a face-to-face conversation with the caregiver or the patient, then you can find an alternative means to communicate with the patient. Okay? Then there's the other out that says if a patient refuses, you don't have to do it. Okay, so tell me, what's the typical conversation that you might have in a community pharmacy? And you're not going to offend me at all. Do you have any questions about your medications? And sometimes you'll see them doing this. Don't ask me a question. I don't have time. So do you have any questions about your medications? Oftentimes it's not even the pharmacist that's asking you, right? It might be a technician or somebody else that's working the register. Any other experiences you want to bring up there? They're good.
Sometimes it's just electronic version. Do you want to be counseled? You know, that thing that you have to sign at?
Right.
So then people are just looking, and then busy people like us just don't get that and want it. Other people may actually read it.
Yeah, so sometimes you don't even know what you're signing, right? They may say, this is for something, but the screen is just the signature blank. So, right, they could be feeding me a line of bull and I have no idea. I may have just signed a will. I have no idea. So, yeah, so a lot of times the communication is very brief. It is the patient refusal is seen as a patient saying, no, I don't have any questions, right? But you know as well as I do that there's lots of times that the patient's not necessarily, there's an asymmetric information, right? You have a lot of information about pharmacotherapy, so do pharmacists, and the patient doesn't know what they don't know, right? But we just assume that that's fine. If you don't have any questions, fine with me. I've got 24 other prescriptions to fill this hour. I'll see you. Call me if you have any questions. I'm not going to call you, but call me if you have any questions, right? Community pharmacists are required to check the controlled substance monitoring database prior to dispensing all controlled substances. True or false? All right, 87% said true. It's actually false. So pharmacists aren't required to check. Actually, pharmacists have a pretty good out. They don't have to check unless they are reasonably certain that someone is trying to obtain a controlled substance in a fraudulent, illegal, or medically inappropriate way. Okay, that's really the only time. So that's really limited. It doesn't mean that's when they check. They actually check fairly often, but that's the only time they're required to check. Okay, now I'm going to bring this down to the prescription drug abuse part, and then we'll tie this all together. So you all know we have a pill for every ill type society, right? We like immediate gratification. A lot of times a pill can take care of something much quicker than us trying to take care of it by lifestyle modifications, right? So we like our medications. As far as controlled substances are concerned, and primarily prescription opioids, you all may have seen this before, but there's a pretty high correlation between sales of prescription opioids, overdose deaths related to those, and then seeking treatment for that. So those are from 2010, so that's a little bit of lag, but a lot of overdose death data does lag. This is a little bit old too, but we're in a hot pocket. We're in an area where there's a lot of overdose deaths. There's an overdose death related to prescription drugs about every 19 minutes. In 2013, there were 23,000 prescription drug-related unintentional overdose deaths. So it's a pretty big problem. Right now we have neonatal abstinence syndrome. I just checked the latest surveillance report, 569 cases reported in Tennessee as of August 15th, okay? And there you have your Tylox and some Adderall American flag. So we have a big problem. We're trying to address this. One of the things that we haven't necessarily addressed, but part of it is overprescribing, and this is what the CDC says. I think that's really hard to measure, honestly, but overprescribing is here. And their justification for this is there is a significant difference between us here at 143 painkiller prescriptions per 100 people, so 1.43 per person, and the folks down in Hawaii. Now, I may have less pain if I live in Hawaii too, right? I mean, but But what the CDC says is the health status of those groups can't explain that much variation in prescribing. So our residents aren't that much sicker than Hawaiians. Okay? So we're trying to work on this as well. We've developed this schematic model. I don't know what you want to call it. It's really confusing. But we tried to figure out where does all this stuff fit that we're dealing with, and how does it apply to prevention and public health, population health. So down here, when you've got the non-user and then you've got death, we've got different levels of prevention: primary, secondary, tertiary, and then you could really put Project Lazarus type stuff with overdose reversal with naloxone, for example. You could put that at quaternary if you want to, bringing somebody back from the dead, sort of. So we're dealing with all sorts of different intervention opportunities here. The thing that undergirds them all, and the message that I want you to take home, is you can't do any of it without communication. And it's not just information sharing. That will help, but you got to talk. You got to communicate, and you got to do it effectively. So I'm going to help you see if we can figure out some ways to do that. So we've asked prescribers and pharmacists, these are community pharmacists and mid-level and physicians. We asked them, would it help to improve communication between pharmacists, between you and pharmacists, or between, if it's a pharmacist, between you and the physician? And overwhelmingly, we hear, that 86% of prescribers say, we need to improve it. And then in the 90s, you find pharmacists. Then you ask them, how do we do this? I have no idea. So nobody really knows how to do this, or what does optimal communication look like. So that's something that we're trying to figure out as well. So what are your barriers that you've had in practice, wherever life might find you, wherever you are in your career path? What are some barriers that you've experienced or heard about as far as communicating with a community pharmacist? Time, okay? Your time, their time, your time. Language? Explain what you mean. Okay. Is that from a patient perspective? Patients can't speak English, so they may have barriers to communicating with the pharmacist or prescriber, with anyone for that matter. Right?
Well, if you call a pharmacist, it's almost a sure thing that you're going to get a voicemail with a series of corrections.
Yep.
And then if you do hold, the hold time will be extensive, at least judged from the position of a practicing physician. Most aren't going to do that.
So phone trees, the rigmarole you have to go through to get to somebody, and then the holding.
If you're a physician's office, it's still going to cut it down a little bit.
Yeah. Okay. The hours that a pharmacy is open, right? So for some pharmacies, you're going to have limited hours, and you may have a call after hours, and so that's a barrier. That it?
Sometimes the different pharmacists, the ones that may have, well, I don't know which direction I'm going to go. They may call you, and when you call back to somebody else, doesn't even know that.
Okay. So you may have different pharmacists. You have more than one pharmacist taking care of a patient. Okay. Anything else?
Patient doesn't want to use his pharmacist. I mean, patient can tell you, I have pharmacy in Jonesboro.
Uh-huh.
It's all information what you get. How many pharmacists in Jonesboro where you have to go? So computers sometimes show the number of pharmacies, for example, 7556. Okay, but you have to spend your time, go to Google, and just find CVS pharmacy with that number, get the number, so it's time consuming.
Okay. So patients don't know their pharmacist or their pharmacy for that matter. Right? One of the most eye-opening things, tell me if I'm wrong, but pharmacy students, but tell me if I'm wrong, but one of the most eye-opening things that we've seen in CPOP, in one of our introductory classes, when they'll interview a patient, and I'm like, ask them who their pharmacist is. Like, what's their pharmacist's name? And 90% of them are like, they don't even have a clue who what their pharmacist's name is. So how many, just throw out some numbers here. How many community pharmacists in the Johnson City area would you say that you know? Would you know? You can name them. Steve. But you're not community pharmacy, right? So that's kind of cheating.
Well, I don't know any either.
Steve doesn't know any either.
But that's a fair point, because the only pharmacists that I interact with on a regular basis, consistently the same pharmacists, are not community pharmacists. They're inpatient pharmacists. Because over the course of a day, if I see 20 patients, they will probably see at least 10 different pharmacists. If they see a consistent one themselves.
Mm-hmm.
Patients who go to chain pharmacies in the community may go to different locations from time to time because it's in the same system.
Mm-hmm.
Yeah, I don't know any community pharmacists. I fill very few prescriptions myself, so I'm not there myself on occasion. My patients don't all see the same ones.
Yeah, and they may not even be within the same system. Your patients may go to multiple pharmacies. I don't know how many conversations I've had with patients when I was in practice that when I was at CVS, for example, and they would get a prescription filled at Walmart because it was cheaper. And then they would ask, does this interact with any of my medications? Like, well, where do you get your prescriptions filled? Well, I get them filled here and at Walmart, and then when I'm at the VA, I'll get them filled at the VA. I'm like, well, I see the ones here, but I honestly don't have a clue what you're taking at Walmart or at the VA. You can't see that? Like, no. I mean, the controlled substance monitoring database can help with that a little bit for controlled substances, right? But overall, you're really limited. And so we're hitting on a lot of stuff that you're going to see in just a minute is a barrier on both sides. Okay? Yes, ma'am.
The other thing is that you don't actually talk to the pharmacist. What you get is the person that's checking it out when it's happening.
Mm-hmm.
You almost never get to talk to them unless it's a problem with your prescription. They may come talk to you
Mm-hmm.
or ask you a question. Usually, it's a busy pharmacy. You're dealing with the person that's checking your allergy. You're not talking to the pharmacist.
Right. Right. Right.
My answer to your question would be, I know two extremely well.
Uh-huh.
I know three that rotate in and out of the pharmacy that my wife and I doggedly use the same pharmacy all the time, as much as we possibly can.
Mm-hmm.
And I know all the techs there. And the reason I do, because I'm a believer that the evidence base says that if you know your pharmacist, you get much better outcomes. I believe that.
You're right. There's a lot of evidence that the collaborative relationship, and not just between physicians or prescribers and pharmacists, between patients and pharmacists, there's all kinds of evidence that those improve patient outcomes, patient satisfaction, quality of life, all kinds of other different things. The problem is they take time to do, right? So your list of barriers looks a lot like the one I made on the pharmacist side. So time is by far up there. You have, 2 minutes per prescription, right? And that's not including everything else that I have to do as far as getting e-prescriptions off of the system. There's lots of other insurance issues, sending stuff back to you via fax or however I might send that back. So there's lots of other stuff going on. So time's an issue. Previous communication efforts, we've seen this a lot. Well, I called the doctor once, and he was a jerk. So I'm not calling back, right? And I'm not making that up, and I'm not saying you're jerks. I'm just saying that's a pharmacist perspective of one. It's kind of a one and done. If I've had a bad experience, it's not worth it. I'll just skip that call. Disciplinary action. Some pharmacists perceive, and this is research that I've done. So some of the pharmacists perceive that they will be reprimanded by their employer if they question prescriptions. This is more specific to prescription drugs or controlled substances, but if I refuse to fill or don't think that a prescription is legitimate, which legally I'm required to do to verify legitimacy, then I may be replaced with another pharmacist because the pharmacist job market's fairly saturated. Okay? So there's that employer interaction as well. Fearful. They're fearful of what you might say if you're a prescriber. They're also fearful of what patients might say if they have to delay getting them a prescription that they might need. Attitudes. That's very broad, but some pharmacists just have crappy attitudes about what their role is in patient care, what kind of interaction they should have with a physician or a prescriber. So there's lots of room for improvement there. Role perceptions. A lot of pharmacists will say that they don't necessarily shouldn't be in that engaged in patient care, and that's your job. It's your job. And they're also not the police. We hear that from prescribers and dispensers, right? So technology, we've got a lot of electronic stuff now. You could argue that sometimes helps, it sometimes hinders communication. And I think there's some good evidence I'll show you here in just a minute. And then you mentioned the revolving door of pharmacists, where you might have floater pharmacists, or you might have one location that has 6 or 7 pharmacists, and it's really hard to get some continuity of care when you have that many people engaging in patient care. Mark Twain's a pretty cool guy. He said some funny stuff. All right, so this is the model from the communication skills course. Pretty standard patient-centered communication model. Rapport building, agenda setting, gathering all your information, open-ended questions, all of that stuff that we've all learned. Active listening, addressing the feelings, ending the interview, and then if you have to reach common ground, that's something that you do as well. And I think that you could argue that these same things apply to prescriber-pharmacist communication. They may take a little bit different spin, and I'm going to try to bring that home for you here at the end. But all these things are just as applicable when you're communicating with a colleague or a pharmacist, whoever that might be. I told you, I changed the way that I talk to my wife based on the communication skills course, right? Because it's not just healthcare related, it's life related. Another good Mark Twain quote. All right, so there's a little bit of literature that I wanted to cover, and I'll tell you right out of the gate that you're not going to find any randomized controlled trials that look at pharmacist-physician communication. And you also don't find a whole lot in the prescriber literature. You'll find a little bit, but a lot of it is coming from the pharmacy end towards prescribers. So 4 of the best ones that I could find in the recent literature are in pharmacy literature. And I encourage you to look at a couple different places. If you're interested in this and interested in honing communication skills, patient-centered communication skills, interprofessional communication skills, health communication, patient education and counseling are 2 good journals to get into. Another one that's more pharmacy-related is RSAP, or Research in Social and Administrative Pharmacy. It's been around for about 11 or 12 years now. It's a really solid journal, solid impact factor. There's some good stuff in there. And then also, Journal of American Pharmacists Association has some. So just to summarize what these bodies of work say, you can pretty much do it on one slide. Information and time are scarce resources. We know that. Okay, so I'm not going to really tell you anything you don't know here, but it may give you a different perspective on the people on the other end. So what kind of information do pharmacists have, community pharmacists typically have about a patient? Med list, right? Typically nothing else in the health record, right? Often not even a diagnosis. So pharmacists often cite that they're lacking information to make informed decisions and also help you optimize pharmacotherapy. Technology can hinder care and collaboration. Phone trees. It's already been brought up. This is something that both groups complain about, and we've had several pharmacists and physicians say, I can't, it doesn't matter, I can't get to anybody. I don't have any way to get to someone in an urgent situation. It's always delayed, right? So if I know it's going to be delayed, I'm not even going to bother to call. I don't have time. So that gets to the next one. Third-party payers are mutually frustrating, right? For every complaint that you might have for a third party, about a third party, pharmacists have an equal number of them. Trust, respect, and knowing are crucial. They've done a lot of research to look at different levels of relationships between pharmacists and physicians. And there's 3, and I'll show them to you here on the next slide, I think. But trust, respect, and knowing. Do you know? I don't really know how you define that. I think it gets more to trust and rapport. But do you know your pharmacist? Do you know the prescribers? the larger population you get, I'd argue that's probably the harder to do, right? It was easier to do in a town of 1,500. It was the pharmacy and one doctor. That was it. So it was easier, pretty easy in the 15,000 size town. When you get up to 60, it's tough. Initial face-to-face visits are important. This was from both the physicians and the pharmacists. How often does this happen? Not very, right? And the literature shows that when it does happen, it's usually initiated by the pharmacist. We're not very good at doing that, though. We're not very good at doing that. Trustworthiness equals consistent contributions to patient care. So from the physician perspective, my trust in you will grow if I show that you're improving outcomes or I show that you are assisting me somehow with managing my patients. Okay? I don't think that we have that link really nailed down between pharmacists in the community and physicians. Now, Steve, that's different, right? But in the community pharmacy, not so much. Framing is crucial. So this gets to how do you ask your question, or how do you approach prescriber. So what we see in our focus groups that we've conducted is a pharmacist would say, well, I'm going to call and I'm going to say, well, that's way too high of a dose. Why are you prescribing that way? But I'm not going to be confrontational, though. Like, well, you just were. Right? The way that you worded that was confrontational. So a lot of the prescribers in these focus groups have said, if you asked it in a different way, it may keep me from giving you my knee-jerk reaction, which is to tell you to go someplace you don't want to go, right? And take your suggestion too. But if you did it in a more professional, respectful way, then you might get more play. That's what prescribers have said. So this may not be all the pharmacists, though. It may be the intermediary. So you all mentioned when you call a pharmacy, you may get the tech, who then may relay a message to the pharmacist. Or if a pharmacist calls an office, then they'll get the nurse or somebody on that line who will then relay the message. So you're playing a little bit of phone, what's that game? Telephone, right? So you have multiple people giving messages, and the more you put in there, the more the message can change. This is a pretty neat breakdown based on quite a bit of focus groups, and these were conducted in the UK. But based on input from several different prescribers and pharmacists, this is how they kind of divvied up their relationships and how much they communicate. So they defined it as isolation, communication, and collaboration. They kind of differentiated between communication and collaboration. So looking at locality, so I'd say oftentimes we're probably here. Would you agree? So community pharmacies and practice sites are not in the same place overall. Yes? All right. Service provision. What does a pharmacist provide? Do they just do dispensing? Do they provide something else like medication therapy management, immunization, something else that can help you with your patients? So there's different levels of that determine the extent to which prescribers and pharmacists communicate. Trust. This is the perception of the prescribers where, I just don't really trust them. I think it's more of a business mindset, not necessarily patient-focused, or they just don't care. Then there's some trust, mutually and historically solid. This takes a lot of time. This is the rapport. The knowing each other, we already talked about. It was interesting that they differentiated between independent and chain in this research. Communication, oftentimes the pharmacist is the one that initiates if there's not really any kind of collaboration there. But then it can get to reciprocal where you have pretty much equal conversations that some might be directed by the prescriber, some might be coming from the pharmacist to the prescriber. Professional roles. This is more of a role specification. And this comes from both sides. It might either be a pharmacist that says, my job isn't to interfere with patient care. That's the prescriber's job. All I do is dispense. And the prescribers might say, his or her job is not to get involved in patient care. Their job is to dispense. That's it. Okay, so there's still that mindset as well. And then respect. There's limited where you don't necessarily think that, I mean, there's lots of people that say the pharmacy isn't even a profession. That's still, it's a para-profession. And then you kind of move along that continuum to where, well, some pharmacists are better than others, and then you have some where you have mutual respect and you have good relationships, like somebody mentioned earlier, where you might know one really well. We do a lot of information giving, I would say. So these are some comments that are from our area. So those were some from the UK, some in different areas of the US. These are focus groups we've done around here that are specific to prescription drug abuse. So real quick, I just wanted to take you through some of the comments. These were done with prescribers and pharmacists. So pharmacist to prescriber communication is lacking and desired. You leave a message and you never hear back. Okay? Both ways. One of the pharmacists said, I think doctors need to have a pharmacy line. Okay? We have a doctor's line, although it may not work, right, the way that it's supposed to, right? But some pharmacists were like, why can't we talk to somebody there quickly and have a dedicated line? That's not common. Prescriber to pharmacist communication is rare, even less so since the controlled substance monitor database was employed. So this was an interesting finding too that we really hadn't thought about, but a lot of them said, well, we used to talk to them, but now that the database is there, I don't need to talk to them anymore. So it was more looking at, you don't get the pharmacist's gut on a patient anymore, or some other data that the pharmacist might have on a patient. You just go right to the database, and you can bypass all of the barriers that keep us from communicating. Prescribing behavior is often questioned by dispensers and vice versa. So I think I already told you that quote up there. If you think about it, prescribers overprescribe, it's hard to talk to them. I know I've done that before, got nowhere. And then in one focus group, we had a pretty good consensus that the local pharmacy was probably doing things that weren't legal. And I don't even trust the pharmacy there because they're handing out the back door controlled substances. Interesting comments. I told you that I'd been robbed one time. One time will change your life. That there are a lot of pharmacists that feel like they get put in danger because, and they blame prescribers. They particularly blame mid-levels. I don't necessarily know why, but that's who they blame. So you now put me and my staff in danger. Thank you very much. Thank you. So there's a lot of fear. But it's sometimes appreciated. So had a couple comments. One person calls me all the time. It's Dr. X. So this is a pharmacist that they do have a pretty good rapport. And it was a small town of about 1,500 again. So the small town facilitates that. And then one physician that, yes, I love it when they call me, yes. So, but what we found out is they love it. You love it when we call you for certain things. And most of the time, it was to save your tail on something, right? Like there's an interaction or something like that where, yes, thank you for calling me, right? Or this person's using 6 other prescribers. Were you aware? So they like that, but for suggestions, things like that, maybe not so much. Okay, so what we've learned. We've learned that communicative behavior is extremely situational. It relies on practice setting barriers. It relies on what your colleagues do that might be in a clinic with you. It also relies on how you're feeling that day and the patient factors as well. Discomfort invites simplification. It's really interesting to see in the communication skills lab where someone will come in and request a narcotic prescription and their prescriber is just retired, right? And what we see in this situation is even if somebody has watched the first 2 people go, 1 person go with a standardized patient, we will see that their initial reaction is, oh, we don't feel controlled substances here. That wasn't in the scenario. They just made that up. Now, why do they do that?
It's easier to shift a lot of the discomfort off the system
Right.
than take it on head on.
Right. because it helps me avoid a tough conversation, right? Because I'm going to have to ask a lot of questions. I may do a risk assessment. I may do some other things that are going to take up a lot of time. If I just say we don't do that, case closed, right? They can say whatever they want. No, I'm sorry, we don't do that. And I've asked pharmacy students at times if it's okay to lie to patients, okay? And they'll say, no, it's not. Well, it just depends. So if somebody's coming in and wants Sudafed, for example, and I think they're shady, I'm going to tell them we don't have any. Okay, that's lying. Well, yeah, but see, so there's sometimes when it's okay to lie. So then they just kind of go back and forth about, sometimes if it makes it easier, you can go ahead and lie. It's okay. Dissonance exists between the patient care model and some current business models. We all know that. They butt heads a lot. Everybody's got their widgets. For y'all, it's patients, patient visits, right? For pharmacies, it's prescriptions. So everybody has widgets. And perceived non-confrontational communication is often confrontational. We see this a lot. And it was really interesting, especially when they would preface a statement by, well, I'm not going to be confrontational or anything, but I would ask them, why aren't you taking your medicine right? Right? That's confrontational. It doesn't get a whole lot more you could one thing that is taught in most of it, motivational interviewing, and pardon my French, but if you can add dumbass onto the end to it and it has the same meaning, then it's probably confrontational language, right? And you can add it on there and it means about the same thing. I think that's pretty applicable. All right, back to this patient-centered care model. So based on this chart, this figure that I showed you that has the 3 levels, the isolation, the communication, and collaboration, how do you take some of these factors like the locality, service provision, trust, the knowing, things like that, and apply them here? So the rapport building goes back to trust and knowing, right? If you have no relationship, the rapport is not going to be there. It takes time to develop. You got to take the time to do it. Based on the research that's been conducted to date, face-to-face is the best way to do that. Agenda setting. So a lot of prescribers feel like pharmacists aren't necessarily patient-focused in their, that isn't their priority, okay? It's more of a business-focused. So the agenda setting has to be patient-focused. It can't be about, this is too much work for me. It's got to be about the patient. Information management, it's scarce. So the more you can do to facilitate information management that's appropriate, the better off I think we'll all be. And that might include some systems level stuff where we need to change phone trees, things like that. Active listening is communication, it's trust, it's knowing. Addressing feelings goes back to professional roles and being open to what other professions can bring to the table. That's on both sides. That's on pharmacists and prescribers as well. Ending the interview, it involves communication and professional respect, and then reaching common ground if needed is about respect, right? So all of these things that influence the extent to which prescribers and physicians collaborate, so taking it beyond the communication, fits right in this patient-centered care model. This patient-centered communication model. So how do we fix that? How do you get from a level 1, where we're typically working in isolation, to a level 3, which I think, there may be some people that don't want to collaborate. I think those are probably few and far between. Those are the exception, not the rule. I think most people want their patients to have the best care. And if that involves collaboration, so be it. So ideas, how do you get there? Yes, sir.
I work in the VA, and very frankly, if we didn't have instant messaging and email, our communication capacity would grind to a halt. It just would. And part of the problem is HIPAA doesn't really allow this, especially not with multiple organizations. And so as a result, I think it's a major challenge. I mean, can you imagine if the banking system ran without the benefit of computerization and everything in banking was done by telephonic connection?
Mm-hmm.
It's unbelievable. Bankrupt the country.
You're right. So HIPAA, what I'm hearing you say is HIPAA prevents a lot of stuff that we could, across systems, might benefit us if we could email, if we could text, things like that. But HIPAA is a barrier.
But then secondarily, for instance, my hospital director will not allow us to use voicemail because the mental health service, if we have an acute suicidality call on voicemail and nobody notices that for 72 hours, that could be a disaster of egregious proportion.
Mm-hmm.
So, you know, it is a very difficult thing. How do you take that explosive information and put it into that irrevocable timeline that is on a single vector? Those two things are very inconsistent,
Mhm.
and that's where the problem comes from.
Yep. Yeah, I completely agree in regards to HIPAA across systems. It's there's lots of barriers there. I think that eventually that won't be a concern. I think we're getting to where we have more secure means of getting that information from one place to the other, but that's definitely a barrier now. Yes, sir.
HIPAA is interesting too, because there's actually a lot of things built into HIPAA to eliminate the barriers that people perceive in placing in
Mhm.
this kind of communication. You know, as an example, I don't need, if I'm in an inpatient setting, HIPAA does not require me to have a signed release of information from the patient to get their medication list so that I can provide care from their pharmacy.
You're right.
9 times out of 10, when I call a pharmacy and ask for a medication list, they want a signed release of information before I send it to them. Even before they'll send it to me.
Yeah.
You know, HIPAA doesn't require that. So an addendum to that is that the implementation of people's perceptions of what HIPAA requires is often what's really standing in the way.
Yeah, that's a good point. You're right, because we've had the same conversation with, in some of our focus groups, a prescriber would say, yeah, you know, a pharmacist will call and ask for a diagnosis code, and I'll tell them I can't give them that from HIPAA. HIPAA prohibits me from giving them. That's not true. It's a mutual patient, and HIPAA allows you to do that. So, yeah, there's a lot of misperceptions about HIPAA. But then you also get policy level layering as well that, you know, to protect our hiney, we may prohibit this company-wide or corporate-wide, right? So, yeah, it's a difficult situation. I'll go through a couple that I think may help, and some of them are more doable than others. Actually, all of them would change the system quite a bit. So I encourage you to make the first rapport building move. Pharmacists aren't good at this, and I don't know if you are or not. But if you all have done strengths and you look at the 4 different areas of strengths where you have the executors, the relationship builders, the influencers, and the strategic thinkers. That's your 4 biggest categories of strengths, the way that people typically or naturally behave. Pharmacists are really lacking in the influencing. Overall, nationally, we don't like admitting influencers into the pharmacy profession, or else they don't want to come into it. One of the two. I don't know, but it's true. We have very few influencers. I had 2 pharmacists in Frankfort, India that I had 2 prescribers that I was really close with. And the only way that I got close to them was they were family friends. They were in our house. They just happened to be prescribers in that town. One was an OB, and one was family medicine. We did other things with them in the community, and then that developed a trust to where they were texting me drug questions and things like that while I was at work. Not patient information in there, but drug questions to help them help their patients. It took a long time, and it took stuff outside of the practice setting to get it going. I encourage you to explore some potential pharmacist roles that can help your patients. So I can remember vividly times in practice when a physician would call me and say, hey, Nick, I think that this patient could really use some counseling on like blood pressure just in general, and I don't have time to do it. Can you do it? Pharmacists eat that stuff up. And I know that we're strapped for time, but we like it that you put trust in us to actually help a patient with something like that. Okay? So I encourage you to think outside the box there as far as what roles can you give to your community pharmacist to start that rapport building. I think you'll be surprised how much they like that you ask. Okay, and then finally, think outside the box when it comes to clinic staffing. This may be a way out there idea, and I know we're about out of time, but typically right now we have intermediaries, right? And this is different in an inpatient setting, but in an outpatient setting, typically a pharmacist is not employed there, right? So in most clinics, you might have an ambulatory care pharmacist that's seeing patients, but you don't typically have a pharmacist there that's managing medication. So something I would like to look at, and as far as I know, this has not been researched at all. I've looked around because it seems like sort of a common sense thing to me, and I know that we're expensive. However, what if you put a pharmacist into a family medicine clinic, into a mental health clinic that was responsible for a lot of the stuff that you have headaches about? They were the person that contacted the pharmacist. They were the person that helped you do med rec. They were the person that took a lot of the headaches off of you that involved medications. They were the person that was doing prior authorizations. They were the person that was looking at guidelines and trying to figure out which most appropriate in this situation. That's a different model, and we're expensive. And we need to figure out, does that really work? Is that a viable model? Do you improve quality? Do you improve patient outcomes? Do you cost too much? How many prescribers could have one pharmacist serve? I don't know the answer to that. But that's a different systems level model that might take some of this away, where you have a pharmacist that's in your clinic, right? And you have a good relationship with them because they help you often, and then that person is the person that communicates out to the community pharmacist. Both have roles, just different. I'll leave you with that. Any questions? This is one of my favorite Mark Twain quotes. I hope you learned something. I hope you, I challenge you to challenge the system, challenge the status quo. And if I can do anything to help you do that, then by all means, get in touch with me, and I'm happy to do that for you. So thank you for having me.